Hey everyone, let's talk about tumors of the ovary. This is WHO Female Genital Tumours 5th edition. So, tumors of ovary can be epithelial tumors, then we have germ cell tumors, sex cord stromal tumors, and mesenchymal tumors, and other mesothelial and miscellaneous tumors. So, in epithelial, we have serous tumor, then we have mucinous tumor, we have seromucinous tumor, we have clear cell tumor and endometrioid tumor. If you'll remember like this, you'll remember serous, mucinous, seromucinous, clear cell and endometrioid, and then Brenner's tumor and other carcinomas. Then we have mesenchymal tumors. Then we have mixed epithelial and mesenchymal tumors. Then we have sex cord stromal tumors, germ cell tumors, and miscellaneous tumors. Other than that, we have mesothelial tumors in ovary, and we can have tumor-like lesion and metastasis in the ovary from other organs. So today we are gonna talk about serous tumors. So let's start. Okay, so in serous tumors, the first one is serous cyst adenoma or adenofibroma and surface papilloma of the ovary. Okay, these three, serous cyst adenoma, adenofibroma, and surface papilloma, are benign serous tumors, and they're composed of cells resembling fallopian tube epithelium. Okay, now the subtypes are serous surface papilloma, serous adenofibroma, not otherwise specified, and serous cyst adenofibroma, not otherwise specified. Location is ovary. Clinical features, if we talk about, then the patient often presents with symptoms related to an ovarian mass or tumor may be found incidentally. Okay, if we talk about epidemiology, patients present over a wide age range, and if the etiology is not known. So, if we talk about the pathogenesis of these tumors, the DNA copy number changes may be seen in the stromal fibromatous cells and rarely in the epithelial cells. If we talk about the gross appearance, the tumor vary widely in size, but cyst adenomas, they exhibit smooth outer and inner surface. They may be septated and filled with watery fluid. This is important. They're not filled with mucinous fluid. That's how we separate them from mucinous tumors. So cyst adenomas will be smooth outer and inner surfaces, and there could be septations, but they will be filled with watery fluid. Okay, and cysts less than 1 centimeter are designated as cortical inclusion cyst. Cyst adenofibromas contain cysts surrounded by variable amount of solid areas. Adenofibromas are typically solid and punctuated with small cysts, and surface papillomas are exophytic. So if we talk about cyst adenoma, then it will be smooth, both outer and inner surface, and filled with serous fluid, and it could be separated. Okay, if we talk about adenofibroma, they will be solid. Okay, if we talk about surface papilloma, they will be exophytic growth, and if we talk about cyst adenofibroma, then they will be both cystic as well as solid areas. Okay, if we talk about the histology, then there is this epithelial lining of this tumor consists of non-stratified cuboidal or columnar cells, which is resembling tubal secretory or ciliated cells in varying proportion. In some tumors, the epithelial lining is flattened and nondescript. Serous cyst adenomas are predominantly cystic. Serous adenofibromas are composed of small glands and cysts in prominent fibromatous stroma. Okay, there will be a cyst, but there will be prominent fibromatous stroma, whereas cyst adenofibromas have cyst and broad and simple papillae embedded in prominent fibromatous stroma. Surface papillomas will have small simple papillae. If less than 10% of total tumor volume, except for surface involvement, shows epithelial proliferation within the cyst, that would otherwise qualify as serous borderline tumor. The tumor is designated as serous cyst adenoma with focal epithelial proliferation. So what is saying is, if the surface papilloma, generally they will have small simple papillae. If less than 10% of the total tumor volume, shows epithelial proliferation within the cyst that would have otherwise qualified as serous borderline tumor. The tumor is designated as serous cyst adenoma with focal epithelial proliferation and not serous borderline tumor. Okay, so as in this image we can see the gross image. This is ovarian serous cyst adenofibroma. So we have the tumor which is typically cystic and cyst lining is very smooth with some nodular areas. We have a nodule over here, and then in this second photomicrograph we can see serous cyst adenofibroma. So we are having the glands which are lined by tubal like epithelium, and we have this thing occasional ciliated cells also. The stroma is fibromatous stroma is present. So this is serous adenofibroma. Okay, now essential and desirable diagnostic criteria. If we talk about this tumor with benign serous epithelium, uh, with or without fibromatous trauma for cyst adenoma, the cyst should be more than 1 centimeter. If it is less than 1 centimeter, then it will be called as what? Cortical inclusion cyst. Okay, now if we can see in this photomicrograph, this is serous surface papilloma. It would be an exophytic growth grossly, and there will be on microscopy there will be stromal papillae which are covered by bland tubal like epithelium project from the ovarian surface. So we have these papillae which are projecting from the epithelium, and they are having bland tubal like epithelium. Next is the serous borderline tumor. Okay, the borderline tumor is non-invasive, low-grade and proliferative serous epithelial neoplasm, non-invasive and low-grade. Okay, so this could be serous borderline tumor either micropapillary or cribriform. Localization obviously ovary, and if we talk about clinical features, the patient presents with symptoms attributed to an ovarian mass. So we have the pictures in these photomicrographs. This is the serous borderline tumor. Okay, there will be papillae forming, and these papillae are architecturally complex papillae with hierarchical branching. Complex means they are having multiple branching. They are originating, then they have this, then they have this, like this. Okay, and in this B1 we can see papillae lined by stratified epithelium with detached small clusters of tumor cells. So we have these papillae. This is a papilla, and these clusters are detached. Okay, so this is serous borderline tumor. In this photomicrograph we can see micropapillary, means there will be small papillae. Okay, and in this one we have elongated micropapillae directly emanate from a large papilla producing the so-called medusa head appearance. Okay, so this is a large, we can see the fibrovascular core. This is a large papilla, and we are seeing multiple micropapillae originating from in here. So this is called as medusa head appearance. Okay, here also we can see epithelial type non-invasive implants associated with ovarian serous borderline tumor. In A we have complex papillary architecture present with an epithelium lined space, and in B we can see the cells are having low grade nuclear features, and we can see the calcification over here. The sarcoma bodies are present. In this photomicrograph, we can see desmoplastic non-invasive implants associated with ovarian serous borderline tumor. In the A image, there is low-grade simple glands. We can see the glands over here, and the epithelial stratification are present within abundant. We have desmoplastic stroma. So in B image we can see individual epithelial cells which are marked by this arrow, and they are present in abundant desmoplastic stroma. So if we talk about pathogenesis, there will be KRAS and BRAF mutation, which are most common in these tumors, and they are less frequent in advanced stage than in stage 1 tumors. If we talk about macroscopic appearance, then these tumors are generally more than 5 centimeter and may be intracystic and lined by excrescences or exophytic with surface involvement. Approximately one third are bilateral. Okay, so this bilaterality is more common in micropapillary or cribriform subtype. So if you talk about grossly, they will be, so size is really very important in these ovarian cysts. It is more than 5 centimeter in case of borderline serous. Okay, if we talk about histology, so typical serous borderline tumor is characterized by branching papillae with variable amount of stroma in the cores. The epithelium is stratified with tufting and cell detachment, as we already saw, and there is an admixture of cell types and nuclei are heterogeneous. Variable number of eosinophilic cells containing moderate amount of cytoplasm are often seen as budding free floating clusters and single cells also, and in this intracystic epithelial proliferation accounts for less than 10% of the tumor. The neoplasm should be classified as serous cyst adenoma, adenofibroma with focal epithelial infiltration. So this we have already read also, that if this intracystic epithelial proliferation is less than 10%, then it would go in serous cyst adenoma or adenofibroma with focal epithelial proliferation and not borderline. Okay, borderline will have more than 10%. The micropapillary or cribriform subtype has elongated micropapillae with stromal cores at least 5 times longer than wide. Then that directly emanate from large papillae, so the so-called medusa head appearance, and small punched out cribriform spaces. An area of pure micropapillary cribriform growth measuring more than 5 mm is required for the tumor to be classified as micropapillary or cribriform subtype. The cells have high NC ratio and the nuclei are small and uniform with small nucleoli. The nuclear features should not be high grade and mitosis are infrequent. Stromal microinvasion is defined as invasion less than 5 mm in greatest dimension in any single focus. Okay, microinvasion means less than 5 mm. Patterns of microinvasion could be small cluster of cells or individual cells with abundant dense eosinophilic cytoplasm within stroma, as well as small papillae within clear lacunar spaces cytologically similar to non-invasive component. No desmoplasia should be present, and these cells may sometimes be within lymphatic spaces. The pattern is diagnosed as SBT with microinvasion. However, if the morphology resembles low-grade serous carcinoma and invasion measures less than 5 mm in greatest dimension in any single focus, the tumor should be classified as microinvasive low-grade serous carcinoma. Okay, the term implant is used in the context of extra-ovarian disease associated with serous borderline tumor of the ovary. Implants of serous borderline are by definition non-invasive. If there is invasion, then there will be diagnosis of low-grade serous carcinoma. Okay. Now, these invasive implants exhibit a variety of patterns, including dense, packed, small nest or papillae, small or haphazard micropapillae, or inverted micropapillary and glandular patterns. Okay, lymph node involvement by serous borderline tumor, which is more common in subcapsular sinuses than parenchyma, may be seen as single cells, papillary clusters, or glandular structures that resemble non-invasive epithelial implants. Rarely features similar to those of invasive implants may be seen. And lymph node involvement by serous borderline tumor is not equivalent to metastatic carcinoma but should be stages and one disease. Okay, so this lymph node involvement is frequently associated with endosalpingosis. However, endosalpingosis in isolation does not warrant assigning a higher stage. If we talk about cytology, there will be papillary structures with relatively uniform small cells, mild to moderate nuclear atypia, and increased NC ratio. Samoma bodies will be commonly seen, and on the basis of morphological features alone, the serous borderline tumor cannot be distinguished from low grade serous carcinoma. Okay, a diagnosis of involved by serous neoplasm can be issued with definitive classification defer to the surgical specimen. Okay, we can advise for histopathological examination for confirmation. So if we talk about essential criteria, there should be epithelial proliferation with papillary hierarchical branching or micropapillary cribriform pattern. Low grade cytology with no stromal invasion should be there. Okay, we also have serous borderline tumor with micro invasion where it is less than 5 mm in greatest dimension in any single focus, with small cell clusters or individual cells with abundant dense eosinophilic cytoplasm or small papillae with clear lacunar spaces. Cytologically, it will be similar to non-invasive component of the serous borderline tumor. So if we talk about these images, this is the A1 is the low grade serous neoplasm, which is the cytology of low grade serous neoplasm. There are papillary structures with uniform relatively small cells and low nuclear atypia. Okay, then we have serous borderline tumor in peritoneal fluid cytology. We have papillae with mild epithelial atypia, and in C also we can see serous borderline tumor with 3D cluster. Okay, so this was about serous borderline tumors. Then we have low grade serous carcinomas, and then we have high grade serous carcinomas. Okay, so if we talk about low grade serous carcinomas, it is an invasive serous neoplasm but with low grade malignant features. Okay, what do you mean by low grade malignant features? This we'll talk about when we'll talk about the histology. Okay, location is obviously ovary, and the patients may be symptomatic secondary to the mass effect or asymptomatic. Ascites may be present. Okay, so if we talk about epidemiology, these patients present over a wide age range, but median is 43 years, approximately a decade younger than those in high grade serous carcinomas. Okay, so these will be younger patients compared to high grade serous carcinomas, and a small subset have prior history of serous borderline tumors also. Okay, now if we talk about pathogenesis, they can exhibit KRAS, NRAS, BRAF, USP9X, and AIF1AX mutations. Okay, so high grade tumors are less frequently associated with BRAF mutation. KRAS mutation is associated with tumor recurrence. Okay, loss of 9p and homozygous deletion of the CDKN2A2B locus have also been reported. Then a significant proportion of low grade serous carcinomas, they arise in association of serous borderline tumor. If we talk about the gross appearance, they will often be bilateral and they exhibit papillary growth. Tumors may be gritty due to calcification. If we talk about the histopathology, they exhibit a variety of patterns, including there could be small nests, glands, papillae or micropapillae, and inverted micropapillae, frequently free floating within unlined clear spaces. Often several patterns of invasions are present with an individual tumor. The nuclei will exhibit mild to moderate atypia with less than threefold variation in nuclear size, occasionally with a central nucleolus. Mitotic figures are present, usually 1 to 2 mm or 2 mitosis per mm square, means 3 to 5 mitosis per 10 high power field of 0.55 mm in diameter and 0.24 mm square in area. Okay, some bodies are often present. Necrosis is rare. Necrosis is common in high grade serous carcinomas. Okay, and they are frequently associated with coexisting serous borderline tumor. Okay, so these tumors are diffusely positive for CK7, PAX8, ER, WT1, and P16 expression is patchy, and P53 exhibit wild type immunoreactivity. So what do you mean by low grade serous? Means the nuclear features, they will show nuclear pleomorphism, but it will be less than 3 folds variation in nuclear size, and mitosis will be low and necrosis will be absent. Psammoma bodies will be present, and there will be association and history of serous borderline tumor. Okay, if we talk about the cytology, the low grade serous carcinoma cannot be distinguished from serous borderline tumor on the basis of cytological features. Additionally, both entities typically exhibit wild type P53 expression and lack block positivity for P16. Okay, if we talk about so we can see over here the gross appearance, the low grade serous carcinoma, this is a large multicystic mass with nodular areas and papillary excrescences. If we talk about the microscopy, this is low grade serous carcinoma. There will be small papillae and they contain the cells which are uniform, which are having uniform nuclei, and mitotic activity is inconspicuous. The essential criteria, if we talk about essential criteria, there should be invasive serous tumor with small nests, glands, papillae or micropapillae, and inverted micropapillae, frequently free floating within unlined clear spaces. Low grade cytological atypia should be there, as I already told, less than 3-fold variation in the nuclear size and low mitotic activity. The staging is this one is staged according to the Union for International Cancer Control TNM classification. If we talk about the prognosis, it is associated with a more indolent clinical course than high grade carcinomas. When confined to the ovary, low grade serous carcinoma has an excellent prognosis, but long term follow up indicates that the prognosis for patients with stage 3 and 4 disease is poor. Okay, in this photomicrograph over here we can see this inverted micropapillary pattern of invasion, means the micropapillae are surrounded by unlined clear spaces, and scattered small papillae clusters and individual cells are also present. Okay, here we can see this peritoneal washing specimen showing numerous papillary clusters of uniform cells, and as well as we can see psammoma bodies. Okay, so the findings in this specimen are not diagnostic of low grade carcinoma and could also be seen in serous borderline tumor. So in cytology we cannot definitely give the diagnosis. It is very hard to differentiate between serous borderline tumor and low grade serous carcinomas. Okay, so this was about low grade serous carcinomas. Now we're going to talk about high grade serous carcinoma. Okay, so high grade serous carcinoma is a high grade epithelial neoplasm with serous differentiation. So the patient's symptoms can be non-specific and related to involvement of abdominopelvic organs. About 80% of the patients present with FIGO stage 3 or 4, and there will be elevated serum CA125 levels, which are more than 35 units per ml in more than 90% of the patients, but it is a non-specific marker. Okay, if we talk about epidemiology, as we already talked about, the mean age is slightly higher than low grade serous carcinomas, and decade higher. Okay, and family history of breast or ovarian carcinoma and infertility are the risk factors, whereas multiparity, breastfeeding, OCP, late menarche or early menopause, these are protective factors. Okay, so if we talk about the pathogenesis, these tumors arise from tubal type epithelium, usually in the fallopian fibria, or less commonly on the ovarian surface or within ovarian epithelial inclusion cyst. Okay, Nearly every tumor harbors a T53 mutation, with the non-synonymous mutation being more common than shift mutation or deletion. Other than TP53, there also be germline mutation in BRCA1 and 2, and a small percentage associated with germline mutation in RAD51C and BRIP1. Okay, so these are all the mutations. If we talk about the macroscopic appearance, they will be bilateral, large, exophytic, and they demonstrate solid and papillary growth, and fluid filled. There will be solid and papillary growth and fluid filled cyst. Okay, the solid areas are tend to white, and they frequently display extensive necrosis will be there. Okay, and the fallopian tube is commonly embedded within the ovarian tumor and cannot be identified grossly. So this will give you a hint that it could be high grade serous carcinoma. There will be large exophytic mass with solid areas as well as cystic areas. Extensive necrosis will be present, and fallopian tube will be adhered or embedded into the ovarian tumor. You will not be able to identify it grossly. Okay, a small tumor nodule is sometimes found in the tubal fimbria also, and this is common extensive extra ovarian involvement. If we talk about histopathology, so these tumors will exhibit solid papillary or labyrinthine within slit-like spaces, glandular or cribriform architecture, and nuclei will be large and marked. Atypia will be there. So to differentiate from low-grade serous carcinoma, the nuclear size will be more than, variability will be more than threefold, and high mitotic activity will be there, typically more than 5 per mm square, or more than 12 per 10 power high power field. Okay, necrosis and multinucleated cells will be common. There will be bizarre looking cells, and unusual morphologies include microcystic architecture with intraluminal and intracytoplasmic mucin can be there, cytoplasmic clearing, and very rarely signet ring cells can be there. Follicular pattern and spindle cells on low power occasional tumors have an architecture resembling that of serous borderline tumor, and they do not demonstrate over destructive invasion, but they should be diagnosed as high grade on the basis of nuclear features. Okay, so homologous recombination deficient tumors frequently display variant architecture which include SCT, solid, endometrial-like, and transitional patterns. Micropapillae and giant cells may also be seen. These tumors display geographical necrosis and prominent lymphocytic infiltrate. So as we can see in these photomicrograph, in A we have SAT, which is solid, endometrial like, and transitional pattern of high grade serous carcinoma with glandular architecture. In B we can see transitional like architecture, and in C this is the WT1 expression, which is diffuse expression. If we talk about cytology, there will be 3D clusters of pleomorphic tumor cells with numerous variably sized cytoplasmic vacuoles, marked nuclear atypia, and range of NC ratios. Okay, so NC ratio, high NC ratio being the most common in dissociated cells. Here also we can see the P53 mutation, IHC with strong nuclear expression. In this we can see a complete loss of P53 in tumor cells, and in C we can see mutant pattern P53 immunostaining with variable